Hello, everyone. This is Gus Cairns. I'm coordinator of PrEP in Europe. And welcome to the first webinar on PrEP and women in Europe. Thank you very much for coming along. We've had some difficulties with people joining. Zoom asked for a passcode when I didn't think it was going to. So if you are here, well done for persisting and re-registering, which is what it seems people have to do. So we will persist with our so far 20 participants, which actually isn't bad. And it's great to see you. Just a quick 2 minutes of your time before we hand over to the first presenter, Sylvain Chawki from Paris. I'm Gus Cairns, coordinator of PrEP in Europe. As you may know, we are a NGO partnership of 6 organizations in Europe, and we conduct a variety of things. We've conducted a couple of PrEP summits. We've had various webinars, and we provide a lot of information and background advocacy data for people who want to advocate for PrEP in Europe. This last year, during the COVID lockdown, we've been concentrating on doing webinars for particular affected groups, especially people not currently well served by PrEP. And this is the first one of 2 webinars about women and PrEP, PrEP for women in Europe. The next one will be on 13th of July. As a way of linking the 2, I will be making notes on this meeting and feeding them through as part of the feedback to the second meeting. Second meeting, we already have 2 speakers. We're waiting for a third. Sophie Strachan of the Sophia Forum, the PrEP advocacy organisation in the UK, and Dr. Vanessa Apia, who is HIV consultant in East London and responsible for one of the largest cohorts of women on PrEP in the UK. Okay, I am going to hand over to Sylvain Chawki from Paris, who works with Jean-Michel Molina, and he is going to present on PrEP dynamics and dosing for women, both cis and trans, both injectable and oral. So Sylvain, if you could share your screen of your presentation, we would love to see it. Thank you very much.
So hello everyone, I'm happy to be there and to present today about PrEP in women and what is new about PrEP in women. I have nothing special to declare, and I'm not going to be talking today about PrEP for intravenous drug users and the barriers to implementation of PrEP in women, because my understanding is that someone else is going to be talking about that today. And I also don't want to talk about the presumed lower adherence of women, because I don't think that it is actually a thing. A word on the terminology. As you can see in the medical studies and the clinical studies, medical doctors can be very archaic in their definition of gender and sex. And a lot of times, cis women is used as kind of an umbrella term for any individual that is born with a vagina. And so I'm going to be using the term cis women as it has been used in the clinical studies that I'm going to be referring to. And so a lot of what I'm going to be saying today about cis women actually applies to anybody born with a vagina, with some nuances about intersex and trans men, because of the potential role of hormones, but I'm going to say a word on that at the end, although we have lacking data. So first of all, is PrEP a good fit for women? Yes, of course, otherwise I would not be doing that presentation today. Originally, we had some studies made on macaques and ex vivo studies made on cervicovaginal tissue that showed that macaques that were treated here in blue with tenofovir FTC, emtricitabine, TDF FTC, compared to macaques that were not treated with the drugs when exposed vaginally with HIV, or more accurately, SHIV. The macaques not treated had high rate of infection, and the macaques that were treated had no rate of infection. We also had proof that in the ex vivo model of infection with HIV, cervicovaginal tissue, when exposed to drugs, the more drugs you had, this is here a study on dapivirine, the more drugs you had in the tissue, the less HIV infection you could measure with here a measure of HIV, which is the P24 value. P24 is a protein of the virus that we use to measure the virus secretion by the tissue. So these were the preclinical studies that showed potential efficacy of the drug as PrEP. And from there, we had clinical studies to show PrEP efficacy in women, although the studies show varying efficacy of PrEP that can be due to various biological factors, also various adherence in some studies. The main takeaway from all the studies is that with daily tenofovir emtricitabine, we can achieve very high rate of protection, and that's why it is nowadays the main recommended treatment for women, daily TDF-FTC. And now that I've said that, what are the new drugs for women and what are the new delivery system? Last time I spoke for the PrEP in women, PrEP in Europe group, I spoke about the rilpivirine long-acting injectable drug, but that drug has been stopped by the pharmaceutical company as a PrEP, and they turned over to the long-acting cabotegravir injectable. So in this study, women were treated with either long-acting cabotegravir injectable every 2 months or TDF-FTC, tenofovir emtricitabine daily. And that study showed that women in the cabotegravir group had a 89% lower risk of HIV infection, showing a higher efficacy as PrEP of the cabotegravir drug. So this is very promising as a PrEP agent. In trans women, the same sister study has been done with MSM and trans women. And in that study, it was very interesting because they had a goal of having at least 10% of trans women included in that study, and they achieved that goal with almost 13% of trans women. And the same results were seen with cabotegravir being more effective than TDF-FTC in preventing HIV. We should always be somewhat careful when we are interpreting superiority of a clinical study that was initially designed for non-inferiority, but in that particular case, they had to stop the clinical trial early because there was more HIV infection in the TDF-FTC group. So this is also very promising for trans women. I will just add that I am very eager to see the results specifically in the trans women group, because so far we only have the results for all infections, and we do not possess the results for specifically MSM or trans women. I wanted to say a word about the dapivirine ring because it has been recommended by the WHO very recently. It is not as effective as TDF-FTC to prevent HIV infection, but it has some preventive effect that has been shown in 3 different studies. The ring study here on the left that was performed in South Africa and Uganda and showed on almost 2,000 cis women 21% risk reduction against placebo. And here in the Aspire study performed in many sub-Saharan African countries, 27% risk reduction. And that same study was continued with an open label study, the HOPE study, and showed this time 39% risk reduction against HIV. So effective for vaginal receptive intercourse, but not as effective as tenofovir and emtricitabine. Just a word on TAF-FTC. So TAF-FTC is a drug that very much resembles TDF-FTC and has been tested in MSM and trans women in the Discover clinical trial, but there was only 1% of transgender women included in that study. And we do not have the results specifics. We only know that there was no HIV infection amongst trans women. So we can say that there is no inferiority between those two drugs. But there is no, so far, no new studies for TAF-FTC in cis women, but I don't see that as likely as you can see here when we are looking at the female genital tract drug concentration of TAF-FTC. You can see that they are more than 100-fold lower than in the rectal tissue. Although in the macaque study, we saw that TAF-FTC showed some level of protection in macaques when exposed with vaginal challenge with SHIV. And for new delivery system, there are implants of islatravir. So islatravir is a new type of drug, which is a new reverse transcriptase inhibitor. And so far, we are in the very first steps of the development of the drug. And there have been only the PK, the pharmacokinetics studies, and they show that with the 56 milligram implant, we can achieve high, reliable drug concentration over 52 weeks of the drug, and that are well above the threshold that is deemed to be protective against HIV. So we are in the very first steps of that drug, but it is very promising for the future. I wanted to say one word for the other news for trans people, because last time that I spoke, we still had a lot of questions about what are the potential role of sex hormone therapy on PrEP and what are the potential drug interactions. And there's not a lot of data on that. But I think the most robust data that has come in the last year is from that study that showed that in transgender men and women, tenofovir level in people taking daily PrEP with tenofovir and emtricitabine were lower than cisgender women and men, but they were well above the protective levels, and they were not related to the levels of hormones. So there is no reason to think that it is related to the sex hormone therapy. So that is the good news for trans people. So all in all, PrEP is highly effective in women, whether it is cis women or trans women. But so far, the main treatment is still tenofovir and emtricitabine to be taken daily. A new recommended treatment is the dapivirine ring, that is only for receptive vaginal intercourse, and the effectiveness is lower than tenofovir and emtricitabine. Some alternatives are on their way. Long-acting cabotegravir seems to be very effective. We have the TAF-FTC that is very likely to be recommended for trans people as well, for transgender women, although we still have kind of a gray area for receptive vaginal intercourse. The on-demand regimen is not likely for women due to pharmacokinetic reasons that we could discuss during the panel if you have questions about it. And in the new and future treatments, the implants seem to be very, very promising. And if you have questions about the broad neutralizing antibodies and the vaccines, I'll be happy to take them. I wish to extend my thanks to all the people that are helping me with my research. And thank you very much for your attention.
Okay, thank you very much, Sylvain. Yanis, you have a question. Let me have a quick look. Right, can we leave that question till after the three presenters, Yanis? Is that okay? Are you going to be, yeah, you're still going to be around, fantastic, okay. So yes, apologies again to people who've had difficulty joining. For some reason, Zoom wanted a passcode when I didn't realize it did. I thought the registration process simply allowed you to click straight through to the meeting. Please inform your contacts if they're trying to get in through to the meeting that they can re-register and get straight in. Thank you for those of you who persisted in getting here. Because we started late because of that, I'm going to pass straight on to Irene Ogeta from Nairobi in Kenya, who can talk about her work in being a peer advocate for adolescent girls and young women in Kenya, who, as you may know, have one of the biggest PrEP programs in the world. And I asked Irene because I thought her findings might illuminate the way forward for working with women and PrEP in Europe. So Irene, if you want to screen share, we'll have a look at your presentation.
Thank you very much, Gus. Thank you. So I will go ahead and try and share my screen.
Any problems, I can do it.
No, sure, I'm fine. Thank you. So I believe you can see my screen good. Kindly confirm.
It's black at the moment. It says, there it is. Okay, thanks.
Thank you.
And remember to put it on slideshow so we get the full size slides.
All right.
It should be, I think, should be on slide or something like that, or just expand your window. It doesn't matter.
Let me just try and see.
If you can't, forget it. Just do it as it is.
No, let me just try.
Start presentation. That's the thing you need, I think.
Okay, just give me a second for it to load. All right, so I'm not sure whether you can. Okay, perfect.
Just taking its time, I think.
So maybe to go ahead and introduce myself. So my name is Irene Ogeta. I am a young woman leader who is working with ATHENA Network as the Associate Program Officer, Young Women's Advocacy. And basically, I'm going to give a very short presentation of the finding of a project that we did in Nairobi and also in Uganda. So it was the Lan Project, was basically, I'm just gonna try and, it was basically a project that was done in Kenya and Uganda, and it was funded by Dream Innovative Challenge. And we implemented under an organization called PIPE in Kenya in partnership with ICW in Uganda. And yeah, I'm struggling to minimize my screen. Thank you very much, Gus. I'm just struggling to minimize my screen. So, giving an overground of a background of what ATHENA does. ATHENA is a feminist organization, and it works towards advancing the voices of young women leadership in leadership spaces, and as a fundamental component in HIV and gender equality responses. Apparently, we operate in 10 different countries of Eastern and Southern Africa. And this is basically to give an opportunity for us to be able to feel and demonstrate the impact of peer-led advocacy. So basically, that's our key role, just ensuring that we put the young women at the center of all our programs. So I'm going to request you to help me transit to the next slide, please. Good.
Sorry, yeah, I can hear you. Do you want me to screen share instead?
Let me just try and quit the whole, it's too big.
I can do it if you like. So why don't I do that? I think that's probably simpler. Just one moment, and I'll bring yours up. Okay. And then there we are, and I'll put yours up.
Thank you.
I think. Hang on a second. No, I don't know if I'm doing it.
Let me just try this, Goose. Thank you. Let me
Okay, all right.
Get it right.
You
Thank
try.
you. Yeah, let me this will stop. All right. Let me just try and get it right. So all right. I'm so sorry. I don't know why it's taking the whole screen, making it a bit hard to transit to the next page. All right.
There we are.
Yeah, thank you. So the Lan Project was basically, as I explained, it was run by ATHENA and under partnership with the ICWE Uganda and PIPE in Kenya. And it was a dream innovative funded research project that was to get an overview of just trying to explore the views and the preferences of adolescent girls and young women on what they thought about PrEP and the consumption around PrEP, access of PrEP, and just getting to know if they really had an understanding of what PrEP really was that was in Kenya and in Uganda. So our general objectives were to understand and generate collective evidence about the knowledge and the views that they had about PrEP, and also to assess the knowledge that they already had, the skills, the confidence of the adolescent girls. That was before the project and also before the dialogues which we used to contact it was sort of a methodology that we used to reach the girls in the community, and the topics that were listed are just the ones above: the HIV, SRHR in general and in depth, and also to identify the young women who are at risk. And we went an extra mile out of the context of the project to ensure that we did referrals and follow-ups regarding the ones who needed to be placed on treatment and care. So basically, we were I'm gonna try and maybe my face. All right. So our project methodology, because it was a peer focused, we were young women who were trained, and we were actually acting as the lead projects of this particular research project. So it was to promote peer-led advocacy, and in this aspect, we adopted the aspect of peer and community mobilization, where the Lan ambassadors were basically the young women who were trained to act as ambassadors, mobilized and also engage the other adolescent girls and young women to be able to go through the entire research. And it was a qualitative research where we convened community dialogues with adolescent girls in the community. And we held about 10 community dialogues in total, with each dialogue containing about 25 participants. We also our target was adolescent girls who aged between 15 and 24. And because most of them were also in school girls, so we had to also seek parental consent in order to continue engaging these girls, which was very positive from our end. So we had our findings. We had issued these girls with pre-questionnaires that we gave them to fill before we started each community dialogue, which entailed knowledge exchange and knowledge sharing. And we found out that 80% of the adolescent girls had heard about PrEP before, but 43% of them thought it was just a pill taken after unprotected sex, and that clearly takes us to they mistook PrEP for PEP and transmission, and only 33%, about 33% knew it was a pill that is taken every day to prevent them from HIV. So all knowledge and confidence measures improved to in the dialogue during when we were now contacting the dialogue, and it indicated a bit of stability and impact in the community dialogue as a method. So some of the views that the adolescent girls had about PrEP, which I find that are really important, especially for any country, any state which is advocating for PrEP and which is also looking forward to adapting PrEP as one of the preventive methodologies. So they brought up issue of choice, urgency, accurate information, and also understanding. These were very important to them because thinking about whether they will take PrEP or not. They also brought the issue of trust. It was very dominant, and these came from trusting their partners, knowing their HIV status, and knowing if the partners had other partners who made the relevant decisions in regards to consuming and or even taking a PrEP uptake. And there was also access was a critical issue. PrEP being free and also inaccessible clinics with no stockouts, and that time PrEP was not widely spoken about. There was a bit of discrimination about, and also the healthcare provider attitude around the girls that went to inquire about the services, and so that also came out very commonly. There was also an issue of shortage, and rather it's a short term preventive measure because they have to go every 3 months to get tested and then for them to get a restock. So they felt like that was quite an issue for them. But after all that, they also did highlight there are some benefits they felt were really associated with them taking PrEP on a daily basis. So they felt like it gives them a chance and opportunity to stay negative from HIV, and it reduces their stress in regards to trying to use any other preventive methods or just feeling anxious all the time about their status. And these made them stay active in school, including those who are sexually active, because we also had some who are going to school but they were selling sex. It gives them an opportunity to conceive and without any risk of HIV accusations. And this was dominantly in discordant relationships for the young girls and for the adolescent girls and young women. And they're able to have sexual relationships without worry about HIV. So some participants raised the issue specifically about sex work, transactional sex, or having multiple partners. So they did not really have to worry about anything. They also had reduced stress and worry. They had no to worry about contracting HIV, and they could conceive, of course, without any problems. So they also did raise concern because they feared that many participants say they disliked or feared taking pills. And again, this brought the issue of they fear taking pills because of the discrimination with that comes along with taking pills. And also it is tedious for them. They felt it was a bit tedious for them to take the pills on a daily basis. And so they were actually asking if there could be a long-term, like maybe injectable PrEP, which could be easier for them. They just go take the jab once in 3 months, and that will really be of great help to them. And they feared about side effects. Lots of participants cited having worries about side effects they had or even thought about being associated. And this was basically because these are things that they hear. They were going with hearsays about these side effects. So they brought these as worries. And some of the things that they were citing were, loss of appetite, gain of weight, and vomiting, and all this and all that. And they also cited impacts of PrEP on behavior, which also cited with some of adolescent girls talking about moral behavior and potential increase in young girls having more sexual partners because they were certain they had a preventive method. And then there was the deprioritization of contraception and condom. If HIV risk be removed, where adolescent girls cited that they would rather focus on PrEP, which was a HIV preventive method, than struggle negotiating safe sex. And this came and brought the discussion where we had to emphasize that PrEP only prevents HIV and it does not prevent STIs. And someone has to be using family planning for them not to get, unintended and unplanned pregnancy. So managing also the oral pills and using oral contraceptives, they felt that was quite an issue, and they were still suggesting for them to have the injectable. So some of the challenges of PrEP to adolescent girls out of the research that were evident were there is a lot of stigma around PrEP because of the Truvena. If the PrEP has a component of Truvena, which also appears to be in the ARVs. So they felt like if someone sees them taking the pill, they will be judged to be HIV positive because people merely go by what they see in the first picture that they see. That's how they judge. And then there was the HIV stigma, clinical barriers. This was associated with transport to the clinical facilities, opening hours, and healthcare providers' attitudes. And then we had relationships, which brought about trust issues and all that. So, out of the Lan Project, we were able to influence a couple of things. And the lessons that were learned from the Lan Project will influence the Ministry of Health in Kenya to strengthen the PrEP technical working group, which I feel this is something that all countries should adopt because once there is evidence that it's effective and available and accessible, then I think it's one of the best available preventive mechanisms that young women and also other people from all general population who are sexually active to adopt. We also have had exceptional policies developed in Kenya because of the advocacy and evidence that was available around HIV prevention and oral PrEP from Lan Project and other projects from other implementing organizations around PrEP. So all these policies have given us the momentum for PrEP delivery. So Ministry of Health has also given exceptional direction. Um, we also had fulfilling the support, the urgency, the choice, and the rights of adolescent girls and young women is imperative because young women are not are we are homogeneous. We have different needs and priority, and one of our biggest priority is having access to HIV prevention and treatment commodities. So having access to information which is accurate about PrEP and the access of it and the affordability of it all was really greatly influenced by the advocacy that we did around PrEP and the research and the findings that we were able to present to the Health Ministry of Health in Kenya. And so peer-led information, sensitization, mobilization, and support have been adopted, valued, and considered effectively. Adolescent girls and young women want to learn about, discuss, and also share their experiences of PrEP with other adolescent girls and young women. That is basically promote peer-led interventions and projects, to say the least. So they are best placed to understand their points of views. So when I reach out to adolescent girls and we reach out with accurate information, I'm at a better position to convince them that, you know what, this is worth trying and it's
Mhm.
worth adapting compared to when someone else, like an adult, reaches out to them. So there is also comprehensive, accurate, and up to date information. It is very critical in sustaining PrEP intake. So last but not least, my presentation has been a bit long due to technical issues. I'm going to conclude by saying that as we adapt and as we look at implementing PrEP, as we continue to scale it up, we need to further research is needed because we need to understand the views, we need to understand the priorities, and we also need to understand the preferences of the target population that we wish to reach with the information about PrEP and services about PrEP. And as PrEP champion, personally, I have been able to continue to create my social network with adolescent girls and young women to fill the PrEP information gaps left by service providers, increase trust of PrEP, and also help reduce PrEP stigma and misconceptions around it. Thank you very much, because this has allowed us to increase appearance and reduce HIV new infections as we look forward to ending the HIV new infections by 2030. I will stop there. Thank you very much, Gus.
Okay, wait a minute. I need to put my video on again. There we are. Thank you. That's wonderful, Irene. I'm sorry about the technical problems. We seem to be a bit plagued by them today. I put in a comment myself. I mean, I think a lot of these issues apply more in an African context, but there are certain ones that apply to women and people unfamiliar with PrEP generally everywhere, and I'd like to sort of discuss those at the end. Anyway, unless there are any technical questions now. No, Yanis has more of a comment than anything. We will move straight on to Ana Silva-Klug, who is a physician at, I think it's Bellvitge Hospital near Barcelona, isn't it? And she is a physician at the STI clinic there and has experience prescribing PrEP for, well, mainly gay men, but also women. Anyway, Anna, if you put up your screen share, we'd love to hear from you. And same thing with you, you can, that's it. Brilliant.
Okay.
Did I get Bellvitge right? You,
No. Hi.
oh, that's better, yes, we can hear you now.
Good afternoon, everybody.
Oh, I mean, sorry, one more thing. Harriet said, please do remember to speak nice and slowly for the interpreters. Anyway, carry on. Sorry about that.
Okay. So hi, good afternoon, everybody. And thank you for inviting me to this webinar. I'm very happy to have the opportunity to speak about PrEP for women in Europe, specifically in Spain, because it's the country I live and I know. In Europe, the implementation of PrEP is being slow compared to the United States. And here in the map, you can see the status of former PrEP implementation in Europe on October 2020. The countries colored in dark green are those in which PrEP is nationally available and completely reimbursed. As you can see, Spain is one of them. And what do the most important European guidelines say about PrEP implementation? The European AIDS Clinical Society guideline recommends PrEP in men who have sex with men and transgender individuals when condoms are not used consistently, and when there are also other markers of increased risk for HIV acquisition. But they also recommend or say that it may be considered, PrEP may be considered in HIV negative heterosexual women and other groups in risk for HIV infection. This heterosexual women here applies in this context, obviously to cisgender women. The European Center for Disease Prevention and Control published in March 2021 a technical guidance for the implementation of PrEP in Europe. In this guidance, they highlight that inclusion of recommendations specific to MSM population is necessary, but they also say that there is a need to recognize individuals who belong to other population groups that may be more vulnerable to HIV infection, such as cis females, transgender people, people who inject drugs, people in prisons and other closed settings, sex workers and consumers, and migrants from countries with high HIV endemicity, who also have other vulnerabilities, such as having an HIV-infected sex partner, having a sex partner who injects drugs, a lack of entitlement to healthcare, and intimate partner violence. Most of these vulnerabilities affect mainly women. The most important Spanish guideline is the Spanish AIDS study group GESIDA guideline published in 2016. This guideline gives recommendations that are very similar to those from the EAC, but more specific and therefore more restrictive. Applying to GESIDA, PrEP should be recommended in people belonging to groups at high risk of HIV infection, setting the threshold for high risk of HIV infection in more than 2 cases per 100 per year. This definition are included MSM and transgender women who have had condomless sex in the previous 6 months and have also another marker of risk for HIV. In this recommendation, they include transgender women. GESIDA also says that PrEP should be considered in people who may be at high risk or for whom there is some evidence of benefit, such as people with HIV-infected partners without clinical or virological control, sex workers, injecting drug users who share syringes, and people in situations of social vulnerability. In these considerations, they include both trans and cisgender women. But to know the current situation in Spain, it's important to say that the national healthcare system in Spain is publicly funded and provides universal coverage and free healthcare services. Since November 2019, PrEP is fully covered by the healthcare system. PrEP is exclusively provided within hospitals, in hospital pharmacies, and PrEP care is largely based in hospital settings as well as some community-based centers. Because of these peculiarities of the national healthcare system of Spain, the implementation of PrEP came with coverage criteria. These coverage criteria were decided by the health ministry according to a document, a consensus document published in January 2018. The coverage criteria include, on one hand, HIV negative MSN and transgender people with at least 2 of the following risk criteria: more than 10 different sexual partners in the last year, unprotected anal sex in the last year, chemsex use in the last year, administration of PrEP on several occasions in the last year, and at least 1 bacterial STI in the last year. And on the other hand, they include HIV negative female if they are sex workers who report condomless sex. As you can see, these coverage criteria are much more restrictive than those from Guideline. There are not much data about PrEP use for women in Spain nowadays. So I decided to show our data, and I think they are very similar to other hospitals in Spain. In our HIV and STD unit, we implemented one of the first PrEP programs in Spain in June 2018, before the complete reimbursement. 250 PrEP users are currently included in our PrEP program. 245 are MSM, 3 are transgender women, and 2 are cisgender women. As you can see, this makes a total of 2% of women in the program. It's not very much. But why women do not access PrEP programs in Spain? The principal problem, the most important problem, is that the national healthcare system only covers PrEP for women in 2 cases: for trans women with specific risk criteria, like I said, and in cis women if they are sex workers. And PrEP cannot be purchased legally by choice. There are no public campaigns promoting PrEP use, and most of the information comes from the LGBTI community, not reaching cis women. Sex workers often find it difficult to talk about their situation for different reasons, such as being in a situation of extreme vulnerability, social stigma, or fear, since practicing prostitution is not completely decriminalized in Spain. And when we detect in our unit a cis woman who meets Guideline criteria, but not coverage criteria, it is difficult to get them to access PrEP. So I want to finish with some possible solutions to this problem: how to get women into PrEP. Obviously, changing coverage criteria, adapting them to the clinical guidelines. On the other hand, making public campaigns, informing about PrEP and promoting PrEP use, and specific campaigns to reach vulnerable women, such as sex workers. Training on PrEP use healthcare professionals with an important role in women's health, such as gynecologists, midwives, or GPs. And searching other ways to get cis women that meet Guideline criteria, but not coverage criteria, to access PrEP. as we did for all before PrEP reimbursement. Thank you all for your attention.
Okay, thanks very much, Anna. I'm going to take Chair's prerogative and ask a question about your very last remark. I wasn't sure what you meant about women who meet guideline criteria but not coverage criteria. What did you mean about that?
Sorry. Women that, if you see the guidelines, they could take PrEP, but we have a very restrictive coverage. We have very restricted coverage criteria, and only sex workers can.
I got you.
PrEP.
Right. So that's what you were talking about. Yes, and I think you don't have what I call a get-out clause in the Spanish guidelines, which I think we do in the UK guidelines, which is the one that says, or people who are at sufficient risk of HIV, which is what the EACS, a version of that is what the EACS guidelines say too.
They could get PrEP because clinical guidelines say so, but we cannot give them because PrEP is given in hospital pharmacies, and it's not covered. So
I got you. Okay, listen, I am going to hand over to Harriet, who will facilitate the discussion. I'll be feeding questions through to her. So Harriet, you can take over right now to answer your question. I'm not sure whether you've been able to see the questions that people are asking. So do you want me to ask them for you?
Actually, I'll take the privilege to ask some questions first and then come back to you. But
Certainly.
for the moment, I just want to assure everyone that we still have the half hour to discuss what we have heard, which is surprising to me because we have lost some minutes in the beginning due to our technical problems. And now I'm feeling very happy and relaxed that we can discuss and answer probably all the questions that shown up. And I want to thank again Sylvain for the insight to France, and Irene from Sub-Saharan Africa, and Ana for the Spanish data. My name is Harriet, as Gus has already introduced me. I'm a journalist and I'm a sexologist, and I'm in HIV prevention for more than 30 years now, and especially interested in women's issues. And Sylvain, I'm going to have a first question to you because it has been the first presentation, and many of us remember that you came up with the basic information about pharmacokinetics and the tissues and where is the drug going to. And you also gave an introduction about the rectal tissue and the vaginal tissue and the distinction between cis and trans persons. So I want to come back to the question, is it correct to discuss men and women, male and female, or is it better to specifically discuss where does the drug go? Is it in the genital tract like vaginal, cervical? Is it protective for the anal region? Because given the fact that Ana just has reminded us about sex workers and the fact that there are also women have anal intercourse, receptive anal intercourse, would you say that we have some data about women are protected in the anal region? Could you specify a bit on that?
So that is a very interesting question. And I saw in the chat that there is a question about the Dapivering ring. And that's why I specified that the Dapivering ring is for vaginal intercourse only. Because as many of you probably know, women have anal sex as well. And this is always a problem when we are discussing PrEP in kind of a gendered or sex-oriented manner. An ideal way would probably be to try and get out of this gender view of the world and to try and just think about what kind of risk sexual acts people have and whether or not they have receptive fellatio, receptive anal intercourse, receptive vaginal intercourse, that type of acts, and how to protect those acts only. That would be, I think, probably a better way of thinking about how to implement PrEP. Now, we also have to think about the tissues and how the tissues might be different in for example, the female genital tract, and how sometimes they can be different in cisgender people and transgender people. For example, the vaginal tissue in people born with a vagina, and vaginal tissue when there are neovaginal vagina can be very different and react very differently to drug concentration, and especially retention of drug, which is a very, very important parameter to take into account when we have to think about PrEP, and especially the number of days you have to take PrEP after your last sexual exposure. So, well, tough question. I would say that when we have to think about PrEP in women and PrEP in transgender, or PrEP in men and PrEP, and the first thing to think about is to try and think about whether or not there will be receptive vaginal intercourse, because that's kind of the limiting factor. This is the hardest to protect. So that's what we have to try and protect, because it's the hardest tissue to get drugs into. Does that answer your question somehow?
Well, it shows at least how many questions still need to be answered. So thank you for the moment. And I'm seeing Yannis' hand up here. And I think, Yannis, you are going to continue this discussion before I bring the next question. Would you like to put your question here? If it's related.
Have you unmuted him, Harriet?
Yes.
No.
Good afternoon, everybody. How's everyone?
I would never dare to unmute the Yannis.
So
He's done it himself.
Nice to see everybody. Thank you very much for the presentations. I've been putting some comments in the chat. I had a question related to the, in terms of pharmacologically to our Parisian colleague. What are you doing in practice in your clinic for the dosing recommendation that you as a unit, what sort of starting dose? I assume you're saying 7 days until full protection, and then your washout dose, is that 7 days or 28 days? And what is that recommendation sort of in the French guidelines, because I don't remember off the top of my head, for cisgender women? And what are you actually telling women in clinic, like after their last sexual exposure, how long they should continue taking PrEP? And maybe some thoughts from your perspective around the pharmacology around this. Over to you. Thank you.
So that's a very interesting question. That's a question that we have been addressing in the past few weeks, and our unit has been on the forefront of the new guidelines in France for that. So that's a question that we have been asking ourselves quite recently. So so far we are still recommending a lead-in period of 7 days for women, because we don't have any data to recommend the two pills at once, like in MSM, and I don't see how we can recommend that for now. I mean, the first data that we had on that show that it probably won't be working like that in the female genital tract. And as to the days, the number of days after last sexual exposure, it used to be 28 days recommended, and recommended by the WHO as well. But it was based more on the post-exposure prophylaxis way of thinking. And so we went back on that and started trying to think about, first of all, what do people actually do? And we realized that people don't take the full 28 days. And so at some point, there is no point in recommending something that is not done. And when looking back at how long the drugs stay in the rectal and the vaginal tissue after last exposure, it seems more reasonable to recommend 7 days to make sure that we can cover the last exposure. So that's what is now recommended in France and in our unit. So that the recommendations are basically based on what we on what some of the people in our unit wrote up. So that's what we're doing, and that's what we are recommending now in France. And I think that it's probably gonna be the new recommendation for the WHO in the next few months.
Thank you, Sylvain, but I would like to relate this to Ana as well, to the Spanish guidelines. Could you just follow up on how the situation is in Spain at the moment?
Spanish guidelines are very old, are from 2016. Then they do not say something very specific for women, for how to take PrEP in women. And I think we need an actualization of these guidelines, but they are not here because PrEP for women in Spain is now not a thing.
So I'm still passing on this question to Irene, because I think the WHO recommendation is also very important for sub-Saharan African regions and for your work with adolescent girls and young women. Am I right, Irene? Could you share a bit light with us?
Thank you very much, Harriet. I think it's really important. The WHO guidelines are really important, especially to who do we administer PrEP to, and how do we ensure that, how do we even know that this is a person who's at risk? How do we define those individuals whom we consider to be at risk? So I feel like, as my colleagues have mentioned, according to WHO, anyone who falls under any area that there is high HIV prevalence, anyone who has multiple sexual partners, anyone who is also in a discordant relationship, I feel they all fall under the guidelines of the WHO on who particularly should get access to PrEP. And as Sylvia explained, there is that period where you give like 7 days before someone had engaged in unprotected sex the last 7 days. There has to be testing, and then there has to be that also. I think there should be an adoption of 3 months window period, because we understand that the virus takes about like 3 months to be able to be detected in the system. So it will really also be very interesting to have a window period of 3 months as well, added to the provided WHO guidelines.
Thank you, Irene. And I think Gus is going to have a remark, especially on what you just said now.
Yes, you can hear me, can't you? Say yes. Hello?
Yes, we can.
Right, okay. Wasn't sure. Yes, I found was a very interesting point, especially also with relevance to the Spanish guidelines too. I would like to see us moving to a demand model rather than a supply model with PrEP. I think we've been too conservative, partially because there was this sort of concern that people would lots of people who didn't really need protection from HIV would rush to get PrEP and swamp the clinics. That's turned out not to be the case. And especially in non-gay populations, it's about stimulating demand, really. The need isn't matched by the use. And so I think we should try and make criteria as broad as possible, and should concentrate instead on educating and informing people, and especially non-gay populations, about PrEP. There's a lovely saying by Bob Grant, the pioneering PrEP researcher, the man who did IPREX, and he said, and I still stick to this, the indication for PrEP is that the person asks for it. In other words, once people reach a specific sort of level of awareness and knowledge about PrEP, they obviously need that education first, then they're often quite good judges of their own risk. And the fact that they've come forward means that they're probably at risk. They may be too embarrassed to say why they're at risk, but generally, people don't ask for PrEP without needing it. So that's really what I wanted to say. I'm not going to sort of butt in anymore.
And you might have seen many heads on the screens were nodding strongly when you were speaking. So this is a thing of two steps that need to be done. First is to get the information out to those who might need the information. And second is to increase the demand by an individual risk checking. And I remember in Irene's presentation that you had a lot of information on the challenges. And I have seen in the chat that there was some question for, is there a ranking in between the challenges? Is there something that you would put first and that you would put more urgent, especially when we try to find your knowledge in European countries as well? So we might learn from you because you're ahead. Could you give us a kind of order, like you would put it, to bring the information, as Gus said?
So thank you very much, Harriet. So according to this particular research, because it's something that it's a project what we did when PrEP was being rolled out in Kenya, it was not widely embraced, and the information was not widely there. So trying to use those back moments as an example to the current situation and the advocacy that European is also trying to do for people to consider taking up PrEP. I would say that some of the challenges, according to now, when I try to put it with a list of priorities, is the availability of PrEP, because in Kenya apparently it's not being sold. It's available for free in almost all government hospitals and government health facilities. So the availability of PrEP as an important commodity and HIV preventive tool should be guaranteed. It should also, the effectiveness of it should also be guaranteed. You know, people need to have access to information. So the challenges is just lack of information about PrEP, and then so many misconceptions and myths that surround PrEP. And then when you're looking about clinical barriers, which goes hand to hand with accessibility and also affordability, that's how I will prioritize the challenges. And let's not forget that HIV, there is still a lot of HIV stigma, despite so much advocacy around dismantling HIV stigma and and discrimination. So PrEP equally comes with, a lot of stigma. So it's also important that as we consider taking up this advocacy and also pushing for PrEP availability, let us also look for ways of reaching out to people, sensitizing people, capacity building about PrEP to dismantle all the misconception, and also just to preach a lot of awareness so that it doesn't really discourage, because a lot of stigma also affects appearance. So yeah.
I'm reading in the chat that Yanis is commenting on the Kenya PrEP program, and he has said that Kenya has a wonderful PrEP program in his viewpoint. I'm going to ask Yanis to put out and to bring an example what you think could be could serve as an example for us in Europe as well, because there was also this remark, I think it was by Sophie, that we need more healthcare professionals involved, and maybe you could also link to that.
Great, thank you. Just, I mean, my perspective is from the onset, when the two large sub-Saharan African countries that started the first sort of two had PrEP policies and started offering PrEP, South Africa and Kenya. South Africa's approach initially was for sex workers and MSM. First, actually, sex workers in their policy document, then the MSM were sort of like taken out, put back in. It was very much a key population approach, and that kind of the marketing of PrEP was like, it's a drug for sex workers or gay men. Well, Kenya, in its initial approach, was actually kind of more sort of general population. They had, I think their marketing and their posters and the material, they had, you know, heterosexual couple talking about, you know, loving themselves and protecting themselves. And so that approach, and then of course they work with their community-based organizations to try to get PrEP delivered to men who have sex with men and other groups. But the marketing right from the onset in Kenya was, it's not just a gay drug, gay service. And I think that's important. I mean, I see that also in our setting in Greece. Right? I mean, already it's like, oh, it's the drug that, you know, gay men from New York are on. I mean, that's the perception rather than saying it's standard of care, and that in line with WHO's recommendation, it's for any person at risk for acquiring HIV. And you kind of determine that like based on people understanding their own risk, but also in a conversation with, you know, well-trained lay providers and healthcare professionals. And I think just, so that's really why I think it's also a robust, very good program, South Africa's as well. But I think it's just, I'm always impressed by also the insight and the intellect of like Kenyan colleagues around from policy making. They did clinical trial research that fed into kind of WHO's recommendation on PrEP. So it's exciting times, but I think the challenges are well articulated by our colleague, and I think a lot of work forward, but again, congratulations to Kenyans.
And even though we now see that we need probably both the supply and the demand side, I want to go back to Sylvain and to Ana, because you are healthcare professionals. And I wonder what, let's start with Sylvain, what you think about your colleagues in France, what should happen, what must happen, what can happen to increase PrEP perception among healthcare professionals, the relevant healthcare professionals, while Ana is thinking about her answer already.
Well, that's a good question. I think one thing that is important is to have PrEP education early on in the medical studies. I think that should be part of the curriculum early on. I also think that what has been happening in France, the fact that nowadays general practitioners can initiate PrEP and prescribe PrEP is probably helping, because I think that's also a way to diffuse the information when general practitioners can also be aware of that type of drug and a new means of prevention. It will probably be it will increase awareness. I think also just increasing education as a whole in the whole society would help if more people knew what PrEP is about. In general, maybe more doctors would be interested and intrigued by it and would be looking into it. But that is a tough question. I'm still quite baffled when some colleagues don't seem to be knowing what PrEP is and how to react with that, and sometimes don't or seem to think that because one individual is taking PrEP that they are actually someone living with HIV. So it's still there's some miles to go. I think we should start with the med school.
With the
That
med
would be
school
probably a first
training.
step.
And okay, would you agree, Anna, or do you have different ideas?
Yes, I agree. Med school is the first step, but I think for a lot of us it's too late. So now we have to to train our colleagues, mostly those who are who give care for women or other minority groups, other vulnerability groups, and we are trying to here. We are training our colleagues from other departments here in our hospital. We are trying to, and also NGOs from sex workers, because it's another problem here. Sex workers don't get women don't get the information. All information comes from NGOs, from the LGTBI collective. There are no other information channels now in Spain. So I think we have to change the channels.
Mm-hmm. And one more question, Anna, because I've seen in the chat that there was a question for numbers. Do you have any numbers on how many women in Spain are on PrEP already?
Yeah, no, we have no official data, but approximately 4,000.
4,000 women or 4,000 people?
Mm-hmm. People, in general, yes.
4,000. Right, so only 4,000 people, not women.
Mm-hmm. No women.
Just clarifying that.
No.
So I'm asking Yanis, who has his hand on my screen, at least I can see the yellow hand, to unmute himself and to share what you think or what you want to hear from our panelists.
So I think to our European colleagues, I have a question in terms of, I know in France, you're now obviously moved to offering PrEP through your GPs, general practitioners. This is something that I work, directly with the WHO Ukraine country office, and we made that recommendation and it's being implemented, even though PrEP is basically delivered through aid centers. The next phase is, because we also have kind of heterosexual transmission that is not insignificant and concerning in Ukraine, and also the epidemic being fueled from injecting drug use. So one of the thoughts is, we've said this, but we haven't done it at the country level, is actually, and Ana mentioned it very nicely in her slides, is actually getting on board the gynecologists. So, if I just think from the perspective of my country in Greece, we don't really have strong primary care. So people don't have a PCP, GP. Women women have better health-seeking behavior than men, and they go to their gynecologist. And so, the way I think what we should be doing, in addition to the med students, absolutely younger generation of providers that should be sensitized before they leave medical school, nursing school, is actually to grab a hold of the gynecologist and do more training around strengthening SRH and new technologies. I don't like to say PrEP is a new technology, but it is in the eyes of so many. And so I don't know, maybe from the perspective of in Spain or France, what are the efforts around the HIV ID experts kind of doing some webinar training, whatever that is, with their colleagues who are gynecologists as well, because I think that's an untapped area still in Europe, absolutely, and in the rest of the world. So maybe if you can comment on that, Ana or Sylvain.
Yes, we are doing that. We are doing that, trying to train gynecologists, but in a very local way. So I think we have to do that more in all Spain, and maybe webinars, maybe something that can reach more people, because it's very important. Also GPs, because GPs here are not aware of PrEP use. They can't give PrEP because PrEP is it's given only in hospital pharmacies, but they don't know about PrEP very much. So this is also an important training, PP.
So yeah, that's actually a very good idea. So locally, sorry, I was muted for a second. So locally, we have been doing some things as well, but we have been targeting the people doing the deliveries. I'm not sure about how we call them in English, midwives. Is that the word? So we have been training midwives to learn about PrEP. So they cannot prescribe it themselves, but by knowing about it and talking about it and referring people to the Planned Parenthood, they can perform the first screening and pretty much do almost the first consult and prepare women for PrEP. And so by doing that, we have had some success in getting some women into the PrEP program in our hospital. So baby steps. But that's a very good idea.
Yeah, and I'm very pleased, very happy to see that we discussed the issues around PrEP in a broader framework of sexual health and rights and a broader framework of healthcare for women. So now that we are going slowly towards the end of our discussion, I want to ask Gus, what are the questions that we have not yet addressed in the chat? Because I have the feeling we have most of them addressed, and there's one big question that I still have, and I wonder if I could ask all our colleagues from the ICA region, those who get the Russian translation, if there is any specific questions from that community here. I would like to give this still the chance to participate. And in the meantime, Gus, can you look for any not yet answered questions? Would that be helpful?
Yes, sure. I did want to ask Yanis, because you mentioned specifically the dapivirine ring. And in the previous webinar we had, which was the PrEP pipeline webinar that we did jointly with AVAC and the ATG, there was a lot of questions about why the dapivirine ring hadn't been licensed in Europe. Would it be a good idea? Things like that. So I just wondered if you got any comments about that, if you see a place for it in Europe.
Absolutely. Can you hear me?
Yes.
Yes.
So I helped the WHO on this kind of joint approval between WHO and the EMA, where they approve products that are relevant to sort of low middle income countries. So the dapivirine ring was this. So I know we can refer to the efficacy as being modest or moderate. I'm not part of the working group that's writing the technical guidelines right now. I probably will see them at some point, but yeah, we know it's not as efficacious and effective as oral-based PrEP, tenofovir. But the reason it was, it worked. It just didn't work as well, but it became another option for women. So especially in generalized epidemics, where a woman can't negotiate or use condoms and can't use or access oral PrEP, HIV would be like, the result. And so the dapivirine ring would be an additional option. And it's, again, in the spirit of choice as part of SRH services to women. But I think for Europe, your question, Gus, in Ukraine, again, I think it'd be, and I don't think just a Ukraine, I'm just advising the Ukraine right now. I think, again, in the concept of choice of evidence-based tools, I think it should be available. It may not be something that is being kind of, but I would offer that choice to women, and I would make sure the product itself was approved, available. There'd be a policy on it. And I think it definitely has a space in Eastern Europe epidemiologically. But in terms of choice, I think even in Western Europe, and I think we just need a little bit more engagement with the developer, the International Partnership of Microbicides. I had a call with them a few months ago about it for Ukraine, because I said, we'd like to, you know, I mean, I just try to put myself in the shoes of somebody who wants, you know, more choices to keep themselves HIV.
Yanis, I want to stop you here, not just because of the time, but also because you mentioned.
That's what I can say on that.
Yeah, but you also used one word that I would like to emphasize very much. What we need for women who have a demand for PrEP is to have a choice. And to have the choice, we need the information, we need the access, we need the financial the financial aspects covered. So I'm looking at my time counter here, the little watch that shows that we have 3 minutes, that we have 3 minutes left. And I know that Gus is going to say something. So from my side, I want to thank again the very, very great presentations from Ana, Sylvain, and Irene, and all the questions. I'm pretty sure we have at least, well, not really answered them all, but sort of. And thank you very much, Gus. The floor is yours now again.
If I may, I just saw one question that I would like to address really quickly. Someone asked about
sure.
During the study between cabotegravir and TDF-FTC about adherence. And so very quickly, we do not have all the results right now, but basically all the infections that occurred, the HIV infections in the TDF-FTC seem to be, and I'm doing that very quickly, so I cannot go into the detail, but they can be attached to a lack of adherence. All the people at some point stopped taking TDF of FTC or FTC when they acquired HIV. So
now that Gus has only 1 minute, I have to have a little tip for you. Save the chat. If you want to read all the things again, save the chat. And now, Gus, please.
And we have another one. This is so it's a good job. We have our second webinar on July the 13th. Got 2 speakers confirmed. I'm trying to find a woman who is actually taking PrEP and who would be prepared to talk. That would be my ideal third speaker. So if you have someone in mind, please let us know. And I'm also seeking somebody from Eastern Europe, because there are people listening here from Ukraine and Russia, but it's not always easy to talk. Thank you very much, everybody. Sorry about the technical problems. In the end, I think most people who actually wanted to join did, because although we only had 26 participants, I answered all the emails I got from people who couldn't join. So, you know, I think it was okay. So make a date for the 13th of July, same time. We will continue the conversation, which is the great thing about having 2 webinars. I will summarize the discussion, which will be easy to do because we have a splendid chat file. And I would like to thank you all very, very much for joining. I would like to thank particularly Sylvain, Irene, and Anna for speaking, and also Harriet for chairing the discussion in her very fair-minded way, because she's a great chair. And also very much thanks to Miroslav and Zenia. I was listening in on the Russian channel every now and again, and you seem to be doing a splendid job, and we'll see you again on the 8th. Many thanks, and I'm going to end it now. But if you've got an outstanding question, it will be recorded in the chat file. Okay? Thank you very much.
Thank you. Bye.
Bye-bye, everybody.
Stay safe and well, everybody. Take care.